Thanks again, Vivek, for doing this, and Bill for supporting it, and for all the faculty for coming in and helping. It really is so exciting to come back here year after year because we really do learn stuff, and it's nice to have a way to keep pace with it. So I'm going to be talking about developing and health interventions to change behavior, and there are three things that I want to talk about. One, I want to just briefly touch on some context for this field, why it's important, something about the pace at which it evolves. I want to touch on how we think health interventions actually change behavior. And then I want to talk about optimizing the whole health intervention suite for behavior change. Okay, so why do we bother with mHealth technology for behavior change? Three main reasons. One is to expand population reach. So if I'm doing a weight loss study and I don't have to bring my patient population into my office every week, and I can have them instead stand on a Wi-Fi scale at home and transmit their data, they can be 300 miles away. And that really expands reach and reduces burden for them. Also cost, and I'm going to be talking a lot about resource management. If we can replace our PhD trained interventionists with a text messaging intervention for at least part of what we do, that saves a lot of expense. So we hope to reduce cost, increase scalability, and have something sustainable after we pull the expensive people out. And this is the last one, and the one where things are moving the most, and it does have to do with our ability now to access continuous, dense digital data and have a sense what's going on with people in real time. So we have the opportunity to do something quickly in a timely, time-sensitive way. Okay. I'm with Bill. I remember these computers. Back in 1980, when I was in my first faculty position, this was the kind of computer that we were all excited about. This thing weighed 2 tons, and it cost about $1 million, and it gave you a whole 20 gigabytes of memory. And that was really exciting back then because we didn't have anything else. Fast forward 30 years, and suddenly we have these little micro SD cards that cost about $100. They weigh 1,000th of a pound, and they can get 32 gigabytes. Now, last year at least, you can buy for $150, 250 gigabytes on a small micro SD card. So things are changing. They're obviously getting smaller. What's going on? Well, Bill, here I'm bringing back my childhood. How many of you, and I know, Bill, you will remember, Donna, you may remember a TV show called Get Smart? This was when I was in junior high school. And Get Smart was a comedy spy show about this guy who was a secret agent, and he had this great piece of technology. He had a telephone in his shoe. This was in the era when telephones were mounted to the wall. That's the only way you could access a telephone. But he could take off his shoe and have a phone right there. Well, we all wanted one of these things. We thought it was complete sci-fi, a complete joke. It would never in a million years exist. Well, lo and behold, a few years later, we had something the size of these shoe phones. We had these brick phones like Donna was talking about. Their sound quality was terrible, but we had science fiction coming to life and something that was accessible to us. And over time, as you see, the phones have gotten smaller and smaller. So what's going on? It's this phenomenon called Moore's Law. Moore was the co-founder of Intel, and he observed that every couple of years, the number of transistors that you can fit easily on an integrated circuit doubles. And with this comes a doubling of processing speed, memory capacity, and the number of sensors you can get in a device. So this is the context we're coming from. Major change happening fairly quickly, and we work in this thing where the technology doesn't hold still, and yet we have to keep designing interventions that we hope will be reproducible over time. Okay, so we have now had a fair number of mHealth interventions designed. What's the evidence that these things work? Well, Bob Kaplan and Arthur Stone did a review back in 2013 when there were really only 21 mobile health RCTs, and it was only about less than a third of them were showing significant effects on outcomes, which if you consider the file drawer phenomenon, that it's harder to get negative results published, there's probably a whole lot more in the file drawer that's negative results. So this wasn't really too good. If you focused on a problem like obesity treatment, 50% were producing some benefit, but it's a squishy outcome. At one follow-up time, they're producing a positive effect. A few years later, for the American Heart Association Behavior Change Committee, a number of us did a review, again, of mHealth interventions. By this time, there's about double the number, and we're doing slightly better. By this time, about 63%, it's like a doubling of efficacy, but still squishy outcomes, some follow-up showing good results. And we're seeing now that although text messaging may work fine for smoking cessation, in and of itself, it's probably not enough for weight loss. It's a more complicated behavior. And I will just say, as a blanket across the board, I think that for most of our mHealth interventions at this stage, we still are at a stage we need hybrid interventions. We need a human in the loop someplace. We have very few interventions, with the possible exception of text message for smoking, that can run on autopilot just with the technology doing its thing. Okay, so how do we think behavior change mechanisms become involved when you're trying to change behavior with an mHealth intervention? Mostly, and I'm talking for weight loss, diet change, physical activity, smoking, mostly we're using this control systems model, where your behavior, you need to know two things. You need to know how you're doing right now and where you're trying to get to. You need to be able to compare those things, and if they're discrepant, bring your behavior into line with your goal. So this is an engineering model, and it was developed to talk about physical things. So if you think about a flat tire, you can see that the current state doesn't look like the goal, which is this. And so pretty easily, you just keep pumping air in the tire until it looks like the goal state. When we're talking about behavior change, health behaviors, we're usually talking about something a little bit more complicated than something you could eyeball, like a flat tire. We might be talking about something like your goal is a 500-calorie lunch, and you want to know, is this in compliance with it? It's close, actually. Probably depends on what condiments you put on it. But most of us need a little bit more help with making that decision. And so this is some of the first way that mobile health tools began to be used for decision support, because you can look them up in a database and see if that complies. Okay, so what I'm now going to show you is 4 generations of interventions using what at one time was cutting-edge technology, our first Palm Pilot interventions. And then these have evolved. So these are 4 generations of the diabetes prevention program on mobile health devices. So we started out, we had these goal thermometers. You're trying to see, you're tracking your fat grams and your calories and your moderate vigorous physical activity. And the bar is filling up as you're getting closer to your goal. At this point, we couldn't objectively measure in real time what somebody's physical activity was like, so we had to ask them. We knew objectively when we downloaded the data in the lab, but the person couldn't know in real time. That was our first generation, and we were using in-person treatment, which is how the DPP was originally framed. Okay, move along. We now have Androids, and we have the first generation of wireless accelerometer. We have a shimmer that Bluetooths the data to an Android. By now, we no longer are having people come in, we're having them coached over the phone. We have this nice traffic light colored thing that tells you when you're in a safe zone in terms of your calorie allowance and your fat gram allowance and blah, blah, blah. We then move along, we have iPhones, and we have Fitbits, which are low cost and are transmitting the data also to the phone. And then we move along, we have a fancier class of sensor, and we have a little bit more current icons to give you feedback. So my question to you is, Are these the same intervention or are these different? And Carla, you know, you've seen this before, so you can't answer. So how many of you think this is the same intervention? How many of you think it's a different intervention? So most of you think it's a different intervention, which isn't very surprising to me because we are at an mHealth training. So you probably think, I'm guessing, but when I give this talk to technology audiences, they usually say it's different because they're focusing on the technology. The technology is different in all of these things. So of course, it's different. I think it's mostly the same. Oops, let me take that back out of here. Because the, the techniques are the same. The behavior change techniques are all the same. We are having people set goals. We are having them self-monitor and compare how they're doing to the icons that they can see. We're giving them decision support. We're giving them feedback. Sometimes we give them incentives. And we have somebody who's giving them social support and holding them accountable. It's just configured differently on the technology, but it's basically the same behavior techniques. The widgets are different. So now let me put this guy back in. And I think this is a very important reason why we should not allow ourselves to be intimidated by how quickly technology evolves. Because yeah, it evolves quickly, but our behavior change mechanisms evolve very, very slowly, probably not within our lifetimes, or maybe very slowly within our lifetimes. So that's how I tend to think about this. And let me give you an example of the first study that I did that brought this home to me. So this was an early Palm Pilot study, a weight loss study that was done with older veterans in their late 50s and 60s who were being treated for obesity at the VA. They were having the VA's MOVE program, which is run by the VA staff, a psychologist, a nutritionist, an exercise physiologist. And all that we're varying is whether we are giving them that Palm Pilot program to track their behavior or whether they're recording on paper and pencil, which is the classic way that people record diet and activity. None of these folks, again, have seen a Palm Pilot. This is revolutionary technology to them when we show it to them. Okay, so here are our results. The blue lines are the group that was recording with technology. The red lines are the groups that are recording on paper and pencil. Solid lines are the people who were adherent to the rest of the treatments. They attended at least 80% of the group treatment sessions. Dotted lines are those who attended less. So what do we see? The technology alone didn't do any magic. If we gave the technology to these dotted line blue people who were not going to the rest of the treatment, they didn't lose any weight, they gained a little bit of weight. But on the other hand, if we gave the technology to the people that were walking the walk and doing the rest of the engagement and the intervention, then they lost 15 pounds compared to those who went to 80% of the group and were recording on paper and pencil. It gave a leg up to the people that were really trying to master these skills and using all of their resources. So what I take from these early experiences is that it's not the technology alone that's doing the work, it's how the technology catalyzes the behavior change mechanisms that are actually the active ingredient. And so I am very interested in this problem of how can we optimize how efficiently mobile health changes behavior. How can we use this knowledge? Okay, so here's the problem I work with. And what I'm going to do now is to show you a series of interventions using the MOST framework. Billy will talk about it in greater depth later in the week, and we'll go into the more detailed methodology. I'm going to take a more clinical approach and tell you how and why I think the availability of mobile health technology is really a game changer in terms of how we are able to learn what interventions work. The diabetes prevention program is probably our best claim to fame as behavioral scientists. It's our great success story. What you see here is that in this initial study of people with prediabetes, if you gave them intensive lifestyle intervention, as compared to metformin, a drug for prediabetics, you not only produced more weight loss, but you delayed the conversion to diabetes. And a very similar study has been done with people with diabetes called Look Ahead. These, we brag about these. This is the evidence that behavioral intervention does better than drug. Okay. So I have always been shocked when I talk to my physician colleagues about the DPP. They always say to me, "Oh, that's the study that showed that metformin works for prediabetes." But why? Did you go to the same movie that I went to? And I think this is what they're talking about. That if you look at the solid blue bar there, that's the cost of intensive lifestyle intervention, these multiple behavior change meetings, 16 to 36 in the first year. That's the cost for that behavioral treatment. It's about $1,800. We can get the cost down to about $800 if we do this in person with groups, and if we train paraprofessionals like YMCA staff, but it still costs more than metformin, which is the red bar. So I think they are doing an instant negating in their head. They're saying it's just too expensive to be scalable. We'll keep having a nice time, behavioral people, but this is never going to go anywhere. And I think this is our problem, that as behavioral interventionists, we know that randomized controlled trials are the coin of the realm in getting buy-in, getting adoption, changing practice in medicine. When we finally get the funding to do one of these in behavioral interventions, we want at all costs for it to have an effect. And so what we tend to do is we throw the kitchen sink into the intervention mix. We throw in everything that we know works. And so this is what we get. We've got this gorgeous, overstuffed intervention with lots and lots of components, which costs a whole lot, but we don't really know which components are necessary. We don't know whether some are worth the cost, whether some are offsetting others. And we say, oh, well, after the fact, we'll do dismantling studies to sort that out. But how many dismantling studies have you seen? It doesn't happen very much. So what I love about the MOST framework is I see this as a way of doing what Cochrane always thought we needed to do, that because the demand for healthcare will always outstrip the resources that are available, we need to figure out some rational way of distributing the resources to give people what they need, but no more, but make sure they get what they need. So I'm going to show you examples of three types of studies that are done in this MOST framework. And these are, I happen to have these are three that I have funded. MOST is a suite of different intervention designs. As I mentioned, Billy will say more about them. But what these designs tackle is, if you think of the MOST factorial design, this basically is a design to figure out the best average intervention to maximize impact at the least resource consumption for the average patient. In medical language, it's your best evidence-based practice. If you think about what the McMaster group trains you to do, the evidence-based decision-making, you do your search, you find the intervention that is most likely to work for the average person. However, how many of us treat average people? There's individual variability, and we know that. And so smart designs are an approach to tackling between person heterogeneity, the fact that people are different. And what they tackle is the best way to sort that out by evaluating people's treatment response. So smart designs answer questions like, where should I start in treatment? How long should I give something a shot to see if it's working? How much should I step up or step down if it's working or not? Or how do I adapt? This is an adaptive design. The newest one, and it's the one I think we're really excited about, are the JEDIs. These are the ones that get after what Donna was talking about. We know that we're not the same person throughout the day. We vary in terms of our state of risk of eating chocolate, being sedentary for all afternoon, binge drinking, and we now, with our continuous digital data, we have the ability to detect that. And so this, I think, begins to take us towards dynamic, personalized behavioral medicine. Okay, so some examples. This is the most factorial study. We call it the opt-in trial. It's a grant that I've had with Linda Collins. And here's the conceptual model for it. So it's weight loss. We wanted to cut way back in our treatment. And we wanted to use paraprofessionals instead of professionals. We knew people, you don't just walk in off the street knowing a whole lot of stuff about nutrition, so we figured people would need some help. But we were trying to figure out which increments in things that would cost more were worth it. So we wound up comparing a couple of components that we thought would target individual behavior change mechanisms, things that we thought would affect self-efficacy and self-regulation. We thought telephone coaching and text messaging, which would serve as prompts and reminders, might do that. And we thought other things might influence the environment. So do we send your primary care doc a report on how you're doing? Do we train your support buddy in how to be supportive? Do we give you meal replacement, which makes your environment a little bit more user-friendly because it does portion control for you? And what we do is we identify which ones of these components or component levels contribute the most to average weight loss and at what cost. And here are our different components. Most of them are either off or on, no text messaging versus text messaging, no progress report to the PCP, blah, blah, blah. The coaching intensity is 12 sessions versus 24 sessions. And then the plan is we wait till we finish the factorial experiment, we look at the effect sizes, and we take those effect sizes that have an effect and that we can package together to come up with an intervention that's less than $500 because we know that's what insurance will pay. And here's what the design looks like. Every component is turned on for half of the participants or at one level versus the other. Goes on with all these different components. And we have now finished 562 patients in this trial. And our retention, 90% at 3 months, not too bad at 6 months, 84%. We get an 11-pound weight loss, 5.7%. 5% is clinically meaningful. So given the paraprofessional coaching, we're pretty happy with that. Now, and again, Carly, you don't get to say anything because you've seen this. So take a look at these components and take a guess at which ones are going to turn out to be worth paying more for because they have a significant effect. Do it first in terms of cost. What do you think of these components is the most expensive? Coaching, yeah, because you have to pay for 24 calls versus 12 calls. Okay. That was the one I was sure. It ain't the case. The only one of these components that produces significantly more weight loss is training the buddy to be supportive. This is a very good public health message that it's not worth doubling the expense on coaching calls because 12 calls works just fine. Now, my first thought was, oh gosh, this is a botched intervention. They must have all just gotten 1 or 2 calls and then they all went away. But it's not the case. They complied with the calls. They got the 24 call group, got that double the calls, about twice as many minutes. Now, if we were going to implement this as a best practice, the thing to bear in mind is, we're all about context in human behavior. Well, there's also context in intervention effects. What we throw into that kitchen sink is not a component in and of itself. It might interact with other components. And it turns out that buddy training is facilitated by sending the reports to the primary care doc. So I think what we are seeing is that 12 sessions of coaching is perfectly fine to build all the self-efficacy and knowledge base for nutrition that you need. And then where we start to get added variance is where we start to make your environment a little bit more supportive, and we create mechanisms to make you more accountable. So I think this is pretty cool, and also good that we don't have to spend double the money on what we were trying to do. Now, SMART. This is a trial that I have with Billy, and this intervention tackles the question of, we know people respond differently. So what we are trying to determine here is what should be what's our best first-line treatment for overweight and obesity? Should it be just an app alone, or should it be the app plus coaching? And the history of this that makes it interesting is we have stepped care, and we know stepped care works for a lot of conditions, particularly in the mental health arena. For obesity, hasn't worked, hasn't equaled the results of what we've gotten from fixed, stay the same treatments. I think this is because we've waited too long. We have believed you have to take 6 weeks to 3 months to figure out whether something was working. But we have preliminary data saying you can figure it out in 2 weeks. So that's what we're testing. And we are, again, from a public health perspective, suggesting that because we can step people up after 2 weeks, the better place to start is with just the app, that it will be non-inferior to the app plus coaching, and that if you want to maximize your resource utilization, why give people more than what they need? Then the next question is, if somebody doesn't respond, how much should you step them up? And we are looking at a modest step up, where you add just another mHealth component, in this case text messages, or you add another traditional weight loss component like coaching or meal replacement. Here's what the design looks like. We start by randomizing people to either app or app plus coaching. If they're doing fine after 2 weeks, we just keep them going. We check them again. If they were doing fine at 2 weeks, we check them again at 4 weeks and at 8 weeks. And if they're doing fine, they just keep doing what they're doing. If they're not, we step them up modestly with just another, with text messaging. If they're not doing fine, we step them up with coaching if they haven't had it, with meal replacement if they have. The good thing about what this kind of SMART design lets us do is that it's testing an algorithm, an if-then rule, not a fixed treatment package. And this, I think, is how clinicians usually work. If something is not working, if you're giving a patient a treatment that's not working, why in heaven's name would you keep doing the same thing? You change it up. You step it up. And the other thing that's been so far a very good lesson for public health is we are finding that we're only re-randomizing about 50% of people. We're halfway through the trial. So once again, we are finding that people seem to be able to do well with an awful lot less than we seemed to feel it was necessary to put into the kitchen sink. We're not done with the trial. We'll see if that holds, but that's how things look now. Okay, so now the last one, the micro-randomized trial and the JEDI. So here, what's being adapted to is the patient's changing state, and it's 2 different states, as Donna and Billy and Pedya and Erica have pointed out. It's either their state of vulnerability and risk and their state of receptivity to intervention, which may not be high at the same time. These states change rapidly in real time, and we have the ability to get a handle on them with passive sensing. But we may not know how to act on this knowledge, and this is critical. this is a place where people go wrong with these interventions when they're submitting them to study section. Okay, the people who are involved in this is out of the Mobile Big Data to Knowledge study, large team of investigators from across different universities. And the problem that we're studying is relapse to smoking cessation. So what we know is that when people quit smoking, they are at very high risk of relapse initially. Um, uh, if they have a puff, if they try to test themselves, odds are good they're not going to make it. 95% of those test yourself puffs are going to be followed by a full relapse. And when we work clinically with patients, we do everything to try to prevent this from happening. We tell people to page us first, call, and they never do it. So what can we do to try to detect when they're at that state of risk? Well, we know that stress is a predictor of all kinds of unhealthy behavior, and smoking is one of the things that it predicts. And we've got something we can do about stress. We know that people can perform relaxation exercises, and that helps with their stress, but people forget to use them. Maybe we could prompt them to use these relaxation exercises. But when should we prompt them? And this is where JEDI submissions to NIH tend to go off. A lot of people say, well, they're stressed and that predicts their smoking, so we should intervene when they're stressed. But is that really the best time to intervene? Well, might be, but it also might not be. We really are at equipoise. We don't know, because there's two possibilities. What their stress is indicating is a state of vulnerability. They are liable to relapse, to try to self-medicate their stress. But when they're stressed, they also have a lot going on, and it might be the worst time to intervene on them. If you intervene on me when I'm stressed, I'll tell you what I'm going to do with you. It's not very nice. So what we are doing is a micro-randomized trial to answer the question, which is the best time to intervene, in stressed minutes or unstressed minutes? And you need to do that first to have your decision logic to know what your just-in-time adaptive intervention is that you're going to test. So how does this all look? Well, people are wearing this suite of sensors. They're wearing a couple of wristbands. They're wearing a chest strap rig. This is the AutoSense thing, which is a sensor suite, which is picking up ECG and respiration. And people are carrying a phone. And the phone is crawling the data, and the algorithms are now able to be run on the phone so that the phone is classifying every minute as stressed or not stressed. You might ask, how does the phone know how to do that? Well, it knows because Santosh Kumar and his group did laboratory studies in which they used classic laboratory stressors. They had people put their arm in a bucket of ice water, or do the Trier public speaking test or mental arithmetic. They looked at what that physiology looked like, and that becomes the detection algorithm, which is running on the phone. The other thing that's running on the phone is that these minutes, after they're classified, are being micro-randomized. We want no more than 3 interventions per day because we think that would be too burdensome. So what's happening is that there are a lot more unstressed minutes than stressed minutes. So those unstressed minutes have a very low probability of being randomized to an intervention, and the stressed minutes have a higher probability. But that's all being run in the background as well. So this thing is now on autopilot. So if it works, it will be quite impressive. We also have detection studies going on. Nabil is involved in a lot of this, trying to actually detect when people are smoking through the wristbands and when they're eating. And we have ground truth from a Warren camera. So how do we know? How will we tell whether our what did our micro-randomized trial tell us? Which minute is the right kind of minute to push at the intervention? Well, we will know by looking at a proximal outcome. And in this case, what we expect is that if the tailoring mechanism is correct, if we're pushing out the intervention at the right time, it will delay the onset of the next stress episode or reduce its likelihood, and it will also reduce the likelihood that or delay the next puff. And so that will be our signal. That will be how we interpret the micro-randomized trial. Our distal outcome is actually the prevention of smoking relapse. We cannot tell that from our MRT. And that is the case with all of these optimization methods. What you emerge with is an algorithm, and then you need to do the trial, at least from the adaptive ones, the ones that change. You emerge with an algorithm, you have to test that in a trial. Okay, so just to conclude, what I would say is that technology-supported interventions let us expand the reach, reduce the burden, and refine the tailoring, the individualizing of behavioral interventions. And that even though the technology evolves very rapidly, I don't think we should be scared by that, because many of the main effective behavior change mechanisms that are producing the outcomes we want, they really remain unchanged. Although the mobile health tech can be very engaging in and of itself, it's not the widget that's doing the magic. It gives us new compelling sensing and delivery channels to influence behavior change mechanisms. And now, with continuous data, it gives us new information about what sort of state somebody is in. I love these new research designs because I think they really are the way forward in population health. They help us develop efficient and effective intervention packages for the average person. They help us develop self-care rules, decision rules to address between person heterogeneity when people are not responding to the same thing. They answer questions like, what should we try first? For how long? What should we try next? And something that is very new, although I understand Kevin Patrick has a grant in this, how do we get people off of treatment? Because the dependency on our treatments this is a tricky problem. It's a problem for our treatments. It's a problem for weaning people off of technology. Boy, did we see this in the days when we had to give people mobile phones because they didn't have their own ones. When we would take them away, everything would fall apart. It's now a possibility for developing these tailoring rules that specify when and how to address these changing states within a person. And unlike Donna, I'm conventional enough. I still put my thank yous at the end. Of course, I have to thank the NIH and American Heart Association for supporting all of these studies. I have to thank my great team and my collaborators, both Billy and Susan and Linda, and my wonderful collaborators at Northwestern, including Nabil. So thank you very much.